I'm María José Bueno. I'm a nurse, and I'm the quality officer of Grup Sagessa. And since 2005, we have been working on a strategic line on patient safety in our group, and that came about because of the need and involvement of the professionals and accreditation by a commission that we have active in different groups, in different centres of our group. I'm sorry, I can't speak in English, but I will try and go sufficiently slowly so that the interpreter can follow me. In the Grup Sagessa, we have many healthcare centres. These are all the healthcare line centres, primary care, long-term care, rehabilitation, and outpatient centres, as well as acute care. We have residential care. 2 of them are accredited by the Joint Commission, and 4 of our 5 primary care centres are also Jci accredited. We also work in education for age 0 to 3 years, and we focus very much on safety issues for the children in our care. Since 2005, we have worked on different patient safety objectives, taking as our basis many of the JCI standards, and they are applied across all our centres. In 2005, we chose to work on critically ill examination cubicles and crash cards, control of morphine drugs, and control of fridge temperatures. In 2006, we moved on to the prescription and administration of drugs, pain assessment, device calibration, and patient ID. In 2007, we worked on improving sterilization, improving hand washing and hydroalcoholic solutions across all our centres, implementing protocols for analgesia, and also a policy for multi-dose packaging. In 2008, we worked very much on improving our checklists for safe surgery, CPR flowcharts, and then in 2009, we decided to implement new objectives of monitoring and auditing that all these improvements were actually being implemented. And we worked with the Catalan Department of Health, taking part in their Alliance for Patient Safety program. In 2010, we worked on the root cause analysis to identify further improvements that were required, and we took part in more projects of the Department of Health. We also assessed the improvements made on the basis of objectives from 2009. In 2011, we worked in collaborative projects with the Department of Health, as well as some of our own projects. We had semestral audits, 6-monthly audits of progress, patient safety objectives. And we provided training on patient safety at all levels, especially in the emergency departments. And I will explain later about our home medicine cabinet checkups. In primary care, we worked in 2012 especially on, again, collaborative projects with the Department of Health in this area. And I'm going to show you some examples now. These posters that you have on screen were created for the control of electrolytic solutions. This is one of the World Health Organization standards. Those are the red ones, and the orange one are intermediate risk drugs. Again, a control list there. And these are put on the walls at all appropriate control points for checking. Now, as to device calibration, this is very important in our group because, for example, these weighing machines, it's very expensive. It's a huge investment to calibrate them every 2 years, but every device is calibrated every 6 months or 1 year. Here we have test strips for glycemia and urine test strips. And at first, we were the only people doing these calibrations, so people were very surprised initially, but have ended up accepting it. Another area we've worked on is the multi-dose packaging policy, because once a multi-dose package was opened, no one was paying any attention to the expiry once it was opened. And so we have put in place very clear rules there. Another area that the Joint Commission has worked very much on is pain assessment. And this was applied every 8 hours in our hospitals, also in primary care. This is an OMI app protocol that I have on screen. And the example is from our adult care. And then we have the scale here and protocols for analgesics for those professionals who do not have so much experience in their use. We also have here a scale assessment for dementia with an age scale. This is another screen from the OMI app protocols, from odontology, from dentistry. We have a checklist which is applied in primary care and pain assessment again. Another standard that we're working on with the Joint Commission is oral orders. In primary care, many orders are given orally, and we have specified that they must be written down and verified. In risk assessment, this occurs regularly for all patients in primary care centres. And as you see down here below, there's an assessment of chronic pain in all patients. That's one of the constants in our risk assessment. Another area is the risk of falls, and we apply the Downton scale for all patients who arrive at our centres, not just in home care, but in all patients who may be considered fragile. Here we have in red all the things that that require attention. That's for a specific patient, a fictional patient. Here we have two screens. One of them is the blood pressure control, and the other is the evaluation from home support. And it involves the check of medication both at the surgery and in the home. We actually check the patient's medicine cabinet at home. We see if there is any incompatibilities in the different medicines they are using. And then we have audits. Here we have 4 centres up at the top from the Joint Commission. This is from 2010. And 2 residential homes, these ones over here, and they also received Jci Accreditation. Now, every month there is a database where the professionals monitor the patient safety standards. We have progressed from paper records to computer databases. This is the daily check-in for the cubicles for examination of critically ill patients, and that's used in all our hospitals. This is the database for the monthly or fortnightly revision of critical areas. This is for the fridge temperature controls. That is both for food fridges and drug fridges. They're checked every 24 hours and they're linked to the computer system. So that has enabled us to detect errors in temperature controls if, for example, a fridge was unplugged. Also, here we have a checklist for the cubicles, that all proper equipment is present and correct. Here we have, again, the figures for fridge controls, any errors in the critical examination area, expiry of pharmaceuticals. And on this screen, we have indicators specified by the Joint Commission. And down here, we have the control of blood pressure by a physician. And down the left-hand column, you have the specific physicians. And these are hypertensive patients and the relevant data ordered in terms of the professional who's responsible for each one. Now, here we have processes set out in a very simple way, and any professional can access these, and they're ordered in very standard files and folders according to the Joint Commission system. I've also mentioned polymedicated patients, and along with checking their medicine cabinets at home and revising their prescriptions, we have been able to reduce duplication of drugs and conflicts of drugs. And this is just to show you that in Catalonia we have accreditation of healthcare centres. There is a new model for primary care based on FQM standards, and 4 of our centres are in pilot phase number 1. These 4 received the best scores in Catalonia because many of them were applying Joint Commission standards. Some of them have a slightly lower score, and that is because the accreditation requires that the protocols must be applied in every centre. And another improvement that we've worked on with the Joint Commission is improving notification. This is our intranet, which all professionals must access this in order to update patient records. This is the notification system. You have the incident box where this screen comes up for informing the date of incidents, where it happened, how it happened, and so on. That brings us to, we get a notification by the BlackBerry. This is the report, the incident report, and using that report, we get that. I'm a member of the Patient Safety Committee. We get that. If it's very serious, we take swift action. If not, it is passed to the GANBI, which is a working group which analyses these notifications, and is passed to the Patient Safety Committee at Primary Care Services. We have over 1,300 notifications, which in case of 15% of those are from primary care. Most of them have to do with the administration and prescription of drugs, processes, and patient identification. Most cases are harmless to patients. An improvement is the follow-up of improvement actions, because often we found that improvement actions were defined, but we've actually set up this database so that we can follow up whether action was actually taken and improvements implemented. We have these different analysis tools, RCA London and AMFE, and I'll come back to that because I'm sure you don't know it. But these are some of the improvements in primary care. For example, The syringes, we've got coloured syringes so that there won't be errors giving an intravenous syringe to a child where it's supposed to be endovenous. The ID here in the centre, we always check the healthcare card against their DNI, their national identification card. Down on the bottom, this is important. This is AMFE, another of our assessment tools, and where we found that an important source of errors was distraction. So phone calls are never passed through to surgery. They're noted on the physician's work pad, and he returns the call later rather than distracting him mid-consultation. Now we have the warnings as regards allergies and so on. These are sent by email to all physicians and healthcare professionals, and they're available on the intranet. Sometimes they're more specific items. For example, this is put on the intranet, and in order to reach their required section of the intranet, professionals must first see these safety notices. Now, the USVIC is the unit which provides support to the victims of critical incidents, physicians, nurses, and so on. And really, it exists to support those professionals involved in difficult situations. And if there are patients injured, it takes care of that as well. These are leaflets which explain the important steps taken during the year. Why do I say this? Because often professionals provide important information. We can't give direct feedback, but every month there's we have seminars on patient safety. It's very important to have a system whereby we can provide feedback and listen to the professionals directly as well. And what I've done here is we've got the follow-up on Jci Accreditation, and this is just a summary pointing out the strengths and weaknesses of Jci Accreditation. And from our perspective, I am a fan of the Joint Commission, and one of our centres, Cambrils, has changed its structure, and we're going to apply for new accreditation at the start of 2013. And now in November, we have a primary care centre which will be due for re-accreditation as well. One of these centres was the first to get Jci Accreditation in Spain, 2001. That was the centre in Hospitalet, just beside Barcelona. There have been many improvements. There are objectives that are common to all professionals, not just that the patient should be the centre of the system, that would stimulate continuous improvement. And if we don't have accreditation, people would keep on working as they always have done. But weaknesses, that some standards are difficult to fulfill, especially in terms of human resources. We have to bear in mind the legislative reality of our country. The cost is very high, and in times of financial crisis, that's a very important consideration. And of course, it's more and more demanding, and we have to keep up those standards.